Everyone. Thank you for coming. I want to introduce, as if you don't already know him, Dr. Jeff Wilson. He's going to be speaking on D-lights, vitamin D. So let's give Dr. Wilson a big, warm Westminster Canterbury welcome.
Thank you. And can everyone hear all right back? Before we start on vitamin D, there was something I thought was so interesting in the New England Journal just this past April 8th. They're looking at the question of global immunization and the areas that are not getting vaccination, such a small percentage. And at the rate they felt of 6.7 million doses a day, that we would achieve herd immunity in about 4.6 years because of all of the places that are not being, the very poor places aren't getting the vaccine. NPR on Monday talked about the same thing. They feel like it'd be like 2 years. And these very poor countries, their herd immunity is going to be based more on them having had the infection than actually getting the vaccination, which I thought was interesting and too bad. Well, vitamin D is interesting. We're going to start off when I started and got interested in vitamin D, it was really a panacea. It was going to be great for everything. And the first article that came to our attention was a thing by two fellows named Plotnikoff and Quigley, 2003. And they had an article in Mayo Clinic Proceedings titled Prevalence of Severe Hypovitaminosis D in Patients with Persistent Nonspecific Musculoskeletal Disease. Nice long title. But that really wakened us up. And patients and people in rheumatology have so many patients with diffuse active musculoskeletal pain, and often no tests are abnormal, the fibromyalgia problem. And I thought this is going to apply to a large number of these patients, and it did. Now, getting them replaced with vitamin D did not make them perfectly well in all cases, but it certainly helped a significant number. So then we got started looking at vitamin D in all of our patients, and the frequency of low vitamin D levels was terrific. It became a real panacea of great interest when Michael Holick published two articles. One was in the New England Journal of Medicine, and the other was in Mayo Clinic Proceedings again. His was the high prevalence of vitamin D inadequacy and implications for health. One of the things that happened with vitamin D that was interesting is that for about 50 or so years, the normal range was like 5 to 30 or 50. And they changed the normal range then, went up to 30 to 100. That was interesting. At that time, I had only seen one patient that I diagnosed with vitamin D deficiency, and that was a patient of Earl Guthrow's who had diffuse aches and pains, and she had vitamin D deficiency less than 5, and it was basically a thing called osteomalacia, and that's caused where you don't calcify the osteoid of the bones, and if you did a bone scan, it looked like she had little minimal fractures all over her body. Very painful, taken care of well with the medicine. When I started, a lot of the studies that Michael Holick referred to are epidemiologic studies, and as time has gone by, one of the problems, we want to move that up there, I see. One of the problems was that randomized control studies, really the greatest, most specific and well appreciated studies, have not been done, and they've been done now over these past few years, and that's when it's gone from panacea maybe to a pariah. My law office staff, as we checking vitamin D, were so impressed. They felt like 110% of my patients had vitamin D deficiency, and to the point that they actually got me this T-shirt. And it's been fun to wear that on the beach and talk to people about vitamin D. I was doing these epidemiologic studies, which are interesting. It was by a fellow, Dr. Siegfried Heiden, who was a medical student during World War II in Switzerland. And at that time, I wasn't studying vitamin D, but what they found was they'd have this great, interesting case for all the medical students to know about and say, come by and see this unusual case. It's something called a myocardial infarction. It was in Switzerland in the war. They had food rationing, and they weren't seeing heart attacks. So that was, at that time, so rare, so unusual. That was always interesting. And as you know, the other thing about epidemiologic studies, I was doing this as my first job, as a personal note, after Sandra and I had gotten married June 20th. And during that time, she was going to grad school for library science at Carolina. And the way you could tell the married medical students, Fran, you'll remember this, was the married students always had a little brown bag, a nice little sandwich, lunch fixed at home. They weren't buying their lunch at the hospital. And so after about 2 or 3 weeks, I asked Sandra, I said, I had a bologna sandwich every day. I said, aren't you getting tired of bologna? And she said, no. And for some reason, the way she said no, I went ahead and opened up her brown bag, and she had this lovely ham sandwich. And I said, well, the reason you're not tired of bologna, this is ham and this is bologna. And at that point, we decided that I would take care of my lunches then. It's the old thing where I got married, for better or worse, but not for lunch. One of the real concerns about vitamin D is it's composed of 2 words, vital amines, and it refers to things that your body will not produce. You have to obtain exogenous sources. Best example of that was the scurvy in patients on the old sailing ships that needed vitamin C and didn't have it. So that was the fact that your body and your skin will make vitamin D is very important. And in truth, somebody wrote a point at one time, and this is the other thing I wanted to mention, it's sort of new. Listen to this definition. Product of living cells that circulates in body fluids produces a specific, often stimulatory effect on the activity of cells, usually remote from its point of origin. Well, that's interesting. You form this in your skin, it goes all over the body, all these different receptors. More specifically, this is the definition of a hormone. And it comes from the Greek meaning impel or set in motion. And I talked to Earl Guthrie the other night, and the question is vitamin D really a vitamin or is it a hormone? And so maybe in the future we'll be talking about, I don't think it'll be hormone, I don't think it'll be the term, but we may have vitamins. Maybe it may be more of a vitamin. Maybe that explains why the studies are so unusual and just aren't the typical type of studies that we see, with these patients. One of the most common reasons that I found with the patients being vitamin D deficient, and we followed over several years, about 2,700 patients. As we get older, our skin, the good thing it did with the sun, which was make vitamin D, it stops doing it, or else it does it at much lower levels. And I would get patients coming in, often retired gentlemen, 70 or 80 years of age, playing golf 3 times a week in the summer. They came in, they had never used sunscreen, never were going to use sunscreen. They looked like red lobsters. They could not have had more sun unless they'd had a nudist golf club. And their vitamin Ds were all low. So somehow they were not making vitamin D, and I think that's the most common mechanism. We also know that if patients with dark skin, particularly African Americans, that's a real sunscreen, and they are notoriously known for having very low vitamin D levels. That ended up having implications with their COVID susceptibility and mortality and morbidity from COVID. And if any of y'all have seen your dermatologist, I'm sure you have never had a dermatologist say, I want you to get out there and get a really robust, healthy-looking tan. Most of your dermatologists look like Casper the Ghost. They've avoided every single cell and sun ray that they could. As I say, the normal range has changed for vitamin D, and I think it's no surprise. Deficiency, I think everyone is comfortable with saying, is less than 30 of the nanograms per ml are the units of measure. But with this change in this, I wonder, how do we define what's insufficiency? If less than 30, and what level is insufficient? The next question is, what level would be optimal? And patients who have family histories in the family of breast cancer, I really always wanted my patients to be around 50 or 60. The blood test that is looked at is the 25-hydroxyvitamin D. We went through a spell for a while that took a long time to convince some of our doctors to do the 25-hydroxy. Instead, the 125 dihydroxyvitamin D levels just seemed like it would be more, but it never is what you want to look at. Never satisfactory in looking at vitamin D problems. The different forms of vitamin D are really basically 2. And the D2 is a prescription. Some of you have had that. That's the 50,000 international units of vitamin D. That is a lanolin-based pill. And so if you have an alpha-gal problem, you probably cannot take that. Some people can react to it. Some people may not. Also, the D3, which is an over-the-counter preparation, all different sizes, and 125 microgram size is equal to 5,000 international units. That is plant-based, soy-based. However, if you get the gel preparation of any of your pills and you're alpha-gal, you may react to that because the gel is always related to an animal product. I noticed one of the mistakes in this is on the dosage and the initial dosage, where you have initial dosage, you start with vitamin D deficiency treatment and go with the vitamin D, the D2, 50,000 international units a week for about 4 to 6 weeks, and every day, daily, not once a week, you take the D3, 2,000 international units. When we started looking at trying to replace patients, one of the, Phyllis Everett, who's a wonderful oncology nurse, some of you probably ran into her, she really was interested in vitamin D, and she wrote some articles in the oncology journals. She was convinced that it had to all be replaced by D3. And I thought we probably needed a combination, but I was using the D2. And we called back and forth every couple of weeks. And she said, I've got this patient, and I'm not getting the vitamin D level up. What should I do? And we ended up finding mixtures, and everybody has different mixtures that work. Part of that probably relates to pharmacogenetics, how we have inherited tendencies for absorption, maintenance, and metabolism of different medicines, including vitamin D. The thing that brought continued vitamin D's popularity was some of the findings with the COVID. Found low vitamin D levels in patients with severe COVID, increased morbidity and mortality. And among the black patients, which were about 13.5% of our population, they had like 25 or 30% of the cases in the hospital, and they had the highest mortality as well. So their group, particularly with lower vitamin D, has always been a special problem. You do your maintenance vitamin D dosage later on, then according to follow-up blood tests, you have to have that. And I've always been interested. Some of my patients would come back and they'd say, my primary doctor is following my vitamin D. Good news, my vitamin D was normal 6 months ago, so we stopped it. So, well, that's kind of like saying my blood pressure was normal, so I stopped my blood pressure medicine. That didn't make any sense. It's a chronic therapy. Some of the people were reading the same things in some of the journals coming out saying all these different tests have been done now. And it looks like vitamin D is really only helpful for metabolic bone diseases, the osteoporosis, osteomalacia, and so on. And they maybe thought that it wasn't so helpful, but it's been very good in following several things. Families with low vitamin D often are the ones that have a tendency to connective tissue diseases. And lupus was one where the patients often had very, very low vitamin D levels. And that's an inherited type tendency of these diseases, inherit some of your susceptibilities, genetic inheritance. And because of that, if you found somebody with levels extremely low, like 5 or 7, it's often hard to replace them. The maintenance dose in some of these people, I guess the most we ever had are patients that were on like the 50,000 twice a week and every day 5,000. That's a lot of vitamin D. So the next question was, well, gosh, that kind of vitamin D, what about toxicity? And I saw I've seen high vitamin D levels, never saw a patient with toxicity. And the toxicity from vitamin D is extremely rare, and it really relates to how your body responds with its calcium in terms of the vitamin D. The patient that I saw that had the highest level of vitamin D came in from the nursing home. And the rule of thumb then was in order to have vitamin D toxicity, you would have to take the 50,000 international units form every day for 3 months. And this patient had that in this nursing home. She was the grandmother of one of my patients. When I saw the orders, I said, well, this must be a mistake. She said, oh, no, that's what she's been getting. Her level was 141. Her calcium was perfectly normal. She had no symptoms of hypercalcemia. We did a bone density on her. She had the bone density of a 19-year-old. Interesting. And I was sort of free association, things like that always, you kind of get the rheumatologist thinking about it. And, there's some cases where people are deficient in something, and they really need a big blast of it to sort of wake up the cells. And I wonder if in some of these patients, the osteoblast, the bone-forming cells, have not responded and done anything for so long that they really need a very big blast of vitamin D. Interesting. One of my nurses at the free clinic, saw her and was trying to get everybody in the free clinic, everybody to be taking vitamin D who's gotten into the COVID problem. Many of them were not. And she was quite low at 5. And she's taking a massive amount of vitamin D now. I was really happy because hers up around 30. And got her daughter checked as well. We always forget sometimes that the kids are low. But the first samples or problems of vitamin D deficiency were in the kids. And that was rickets. You saw the pictures of the kids with bowed legs where the bones had not formed. Vitamin D sometimes is a tip-off for other things changing in your health. And one of my patients who had Sjogren's syndrome was followed, and 1 year I did her vitamin D and it was like 42, nice and normal. Next year I did it and it was like 38. Next year I did it and it was 8. So what in the world's going on? And she is about maybe 52-year-old white female. And she, for years, she said, well, it's my irritable bowel. Well, irritable bowel doesn't do that. Instead, she'd had celiac disease off and on all that time. And the fat-soluble vitamins are A, D, E, and K. So the D was not being absorbed. And she was developing her vitamin D deficiency as a manifestation of her celiac disease. So once we got her on the gluten-free diet, all that corrected. So it really gives you a tip-off to other parts of the health in your body as well. One of the most important concepts, I think, both in rheumatology with the COVID thing, has been one of immunomodulation. And it's something that's maybe hard to understand, but I think this is where the vitamin D is most important. You want your immune system not to underact, but you don't want it to overact either. And if people on chemotherapy, when their immune system gets suppressed, they're more susceptible to infections. That's when it's underactive. With COVID and a lot of these autoimmune diseases, it's where things get turned on, the immune system, and it overreacts. We're seeing that partly in immunotherapy in cancer. It goes what they do checkpoint inhibition. It goes in and inhibits the areas in the cycle with the medicine and so on that they feel like the immune system is not working to protect against the cancer. So they're going to kind of inhibit that at that point. And that's fine. The immune system then is able to pick up and do more against the cancer. But it also revs up against other inflammatory things. The next thing you know, they have pneumonitis, inflammatory muscle problems, lung problems, and so on. So we'd like to modulate things. If you're treating cancer, certain things come first no matter what. The overactivity with the immune system with COVID has been a thing called hyperimmune response. And part of that has been, you've heard of cytokine storm. Cytokines are just a cascade of different chemicals and reactions that have to do with inflammation. And too much inflammation is bad. The autoimmune thing can do a lot of damage to the body. We feel like vitamin D helps to protect that. We had many patients who were on rheumatoid arthritis, a regimen of prednisone, Plaquenil, and methotrexate. We found that once we got their vitamin D revved up, that a lot of times we were able to start tapering back. First of all, we taper off the prednisone. Well, that was interesting, always nice. Then we taper back on the Plaquenil or on the methotrexate. Another medicine has more toxicity. Getting off that, their arthritis would stay in remission. Then come on back, on the, cutting back off the methotrexate, prednisone, and then the Plaquenil. And we found out a lot of patients on Plaquenil could be controlled with 1 pill a day along with the vitamin D instead of having to take 2 pills. Toxicity of Plaquenil is related to the total dose that you take. And this probably has to do with, again, the fact that the vitamin D allows for this immunomodulation. It controls you where you don't overreact or underreact with the immune system. We get back to the idea of vitamin D as a hormone, vitamone. Maybe it's acting as a catalyst. It's not involved so much in the active, but maybe it just helps to facilitate these reactions around the body, the immune system, and so on. As I said, the gold standard of treatments has been the randomized controlled trials, never done for lung cancer and smoking. don't think there's any doubt about smoking having an effect with lung cancer, but that's what's been done over the last 10 or 15 years. And some of the studies are really hard to understand why they ever did them, but one of them was the fact that if you gave somebody a bolus of 100,000 units of vitamin D, that it didn't do anything for their COVID. Well, I'm sure anyone knows what happens if you give somebody a bolus of vitamin D, in the body, where it goes or what it does. So I think they're doing the wrong studies on vitamin D. My feeling is that you continue to take your vitamin D, just as we recommend in our families, 5,000 international units a day, until we see this stuff get under control, and then according to your doctor's blood test, continuing to have those checked every now and then. One of the reasons we think that the vitamin D is so important, it seems to have an antimicrobial effect. This was suggested in the response in TB sanatoriums before there were anti-TB medicines. Some people went to sanatoriums for a good while, and there was some idea that perhaps the vitamin D actually had an antimicrobial effect working against the TB bacilli. Another suggestion of that was when they did a sanatorium in Mammoth Cave, and the people with no vitamin D or with no sun exposure did dismally. So I think they needed the vitamin D. Some people have the feeling that also the immune system, also as we get older, we're more prone to have the increased morbidity and mortality from things like the COVID-19. And the children end up also, we're starting to see more of this in the children. I've noticed that they're finding more younger cases. Maybe that's because we're all getting vaccinated. That's kind of interesting. But also some of the severe cases in the children where they have a multi-system inflammatory syndrome is akin to a vasculitis type problem we saw in rheumatology called sort of like a hepatitis B, general vasculitis, polyarteritis nodosa. Won't mean anything to you, but again, it's just an inflammatory overreaction. We talked about the low vitamin D levels among our black patients and how that correlated with the increased morbidity and mortality from COVID-19. There have been some really interesting studies in terms of genetics, and I think this is really important in the future. And this is done by GWAS, which Genome-Wide Association Studies. And one of the first ones that has been important in COVID-19 was the finding that the subgroup of people that have the genetic locus for type A blood, ABO locus, that's designated 9q34.2. And then they also had a multi-gene locus, also designated in there 3p21.31. So the people with those, that select group of people were the ones that had a much more severe COVID as far as morbidity, mortality, and being on the respirators and dying. So the idea in rheumatology or any place really is to go ahead and predict the groups that are going to have more problems. And if you can predict that, what do you do to prevent it? Well, obviously this select group of people, knowing ahead of time, if they have not had COVID, they would be the ones you really would like to have high priority to get vaccinated. If they have had it, then they're the ones that you would want to treat earlier with dexamethasone and probably the monoclonal antibody plasma. Daughter Melissa had COVID. She and her son, my grandson, she had a mild case until one day, all of a sudden, after about a week or so, cold-like symptoms, flu-like symptoms, she lost her sense of taste and smell. So she had it, developed antibodies, and went several weeks ago to give plasma for part of the monoclonal antibody plasma treatment, and was turned down. The question being, had she been in England between like 1988 and 1995? She had, studying abroad, and this was because of a possible mad cow disease. They're not allowed to donate blood nor donate these antibodies. I think it's going to be a very interesting future, particularly things coming in terms of genetic studies. It's going to maybe affecting our great-grandkids, maybe our great-great-grandkids. But I think that we're going to see more and more situations where at birth, they're going to get the genome map of the individual. And from that genome map, they're going to say, okay, we know that this group has more problems with Shigella dysentery developing into a chronic arthritis called Reiter syndrome. This group, if they get the COVID, are going to have more likelihood to have severe disease, and all other sorts of these different select groups. And from that, we'll be able to say to prevent things, this group really needs this vaccine against Shigella, this vaccine against COVID, different things that are available, or they need to avoid. They're the ones that particularly need to avoid some of the triggers for some of these diseases. We're seeing this a lot with alpha-gal too, some things that make you think that people are more particularly prone, some select groups. Triggers to avoid would be things like ticks, obviously, with alpha-gal, Agent Orange, silicone implants, sun, medications, and so on. All these sort of things make us think that they can trigger some of these various diseases, particularly autoimmune diseases. There's some studies that we're excited about now that an increase in prevalence of ANA test, anti-nuclear antibody tests, related to increased autoimmunity. They found out, again, with some of these genome-wide studies, there was a group in Ethiopia, people with very similar genetic background, and they were developing a disease that looked like elephantiasis. If you ever remember those pictures from Africa with these great big swollen legs, and that was caused by a parasite, Wucheria bancrofti, that got into people through their feet and caused problems in their lymphatics to develop this elephantiasis. But this whole group, genetically similar folks, were developing this phenotypic presentation like elephantiasis, but it was from absorbing minerals from the red clay, walking barefoot in the clay. And one of we think that maybe, in fact, I'm pretty sure our environment's probably not getting any kinder, probably have more chances of environmental triggers of all these different diseases. That again, we need to appreciate those things and say, how do we predict them, who needs to avoid them, and so on. I think that's going to be the future, as well as being on top of all the vaccines. What I want to do is just leave this open for any sort of questions and thoughts. I think there's some new ideas about vitamin D. The final word is, do you continue to take it? Yes. And at least to no longer have masks, for sure. But even then, I suspect we're going to need it. Any questions? I've thought about a little quiz, asking you to give the.
When should, say, our grandchildren start taking it? What age group? When should you start taking it? A child or when they're an adult?
Well, you know, in our family, you know, our grandchildren started taking it. It was probably about 2 or 3. Yeah. For the little ones, we usually would start, you know, with them like 1,000. But if you look at the recommendations, like the pediatric rate recommendations, they'll say like they should be getting 200, 500 national units a day.
Well, how many if it's over the counter, they come 2 or 3 drinks.
Right.
And how many units per day?
Yeah, international units. I think with the COVID problem concerned, 5,000. That's what we're recommending. It was how much of the question was how much of the many units should be people be taking. And I think the 5,000 international units a day is reasonable for children, adults, young adults, teenagers. I think until the COVID stuff is over, I'd still like to see taking about 5,000.
Even when there's not COVID, I think it's not going to hurt you. It's good to take it. I think it's good, right?
Yeah, and the question is, having taken it for years, not going to hurt you. I think that's exactly right. You know, several of my patients at times would, for some reason or other, maybe the primary doctor took them off of it, and they came back. They really wanted to get back on it. They really felt it helped them in things like hair growth, nails, you know, things that are sort of intangible, energy. It can be very helpful in some of them. Yeah.
Are there any interactions between vitamin D and other over-the-counter things to get hooked on?
Hooked on. The question was, yeah, question about interactions of vitamin D with other things, maybe over-the-counter things, and not to my knowledge. That's a good question. Just have to pay more attention to it. Maybe I'm just missing. Well, for the bonus question is, who can name the genetic locus numbers we had, the 3QP21? Okay, well, that was. Can you imagine that your great-grandchildren who end up needing a kidney transplant or heart transplant, that they take the stem cells that they save from the child at birth and go ahead and develop their own kidney, grow their own kidney, grow their own heart? It's intriguing. Any other questions? Got vitamin D? If you haven't got it, then get it. Thank you.